Right. Yeah, if you get a chance, there's cookies and things after, but if you get a chance, duck into this room back here and you can see the whole control room that our student video production team has set up. It's very impressive. So, we're ready. That was all on camera. Okay, well, good afternoon. My name is Mark Girod. Welcome to the Richard Woodcock Education Center. I serve as the Dean of the College of Education here at Western, and we are on location in the Fireplace lobby in the brand new Richard Woodcock Education Center. Western Oregon University is located in Monmouth, Oregon, and today is Wednesday, November 29th, 2017. As this will be archived, we need to mark that. So, our goal today is that this is the first in a series of what we hope will become a repeated event called the College of Education Fireside Chats. And today we hope to have an intimate yet open conversation about health equity, health disparities, health policy, both locally and on a broader scale. So joining me today on my right is Dr. Doris Cancel-Tirado, Associate Professor of Community Health Education here at Western Oregon University, and our partner today, Dr. Bruce Thompson, retired physician from Benton County and also serving with Benton County Health. So at this point, I'd like to perhaps invite the two of you to introduce yourselves just maybe a little more fully, share with our audience and our observers at a distance, maybe a little bit more about your own expertise and what you might like the audience to know about yourself before we get started.
So let's get started with our guests.
Okay. Yes, so I am a retired family physician, and since retiring, I've gotten very passionate about health equity and universal health care. I've served as the Benton County Health Officer for 20 years, and as many of you may know, what county health offices do is really spread the word and fill in the gaps in our healthcare system, which is quite the opposite of equity. So my passion is to make it more equitable and to learn as I go and to just meet all kinds of cool people doing the same thing.
Thank you. Hello everyone, my name is Doris Cancel-Tirado, and I discovered public health late in my life. I have a background in psychology and mental health counselor, and it was never my intention to be in public health, and I love everything about public health. So my hopes are that many young students and others that are not that young have the opportunity to discover public health and see the value in the work that we do. So that's one of my biggest passion, but I also care a lot about health equity. And we're gonna talk later about why. But I think that some personal experiences and in my work, I have seen the value of achieving health equity for everyone.
Appreciate that. So for not everyone in the room is an expert in this area. So perhaps we could start with just a little bit of a softball question for our two experts, but could you tell us a little bit about what is this thing called health equity and why does it matter to all of us?
When we think about health equity, is the ability for everyone to achieve the healthiest life possible, and not that your social conditions like your race, your socioeconomic status, your education are not the determinants of that health path. And that is a simple definition, and there's other things that go around it. And we cannot talk about health equity without talking about health disparities and things that cause health disparities. And we live in a society that your wealth, your zip code really determine your health. And it make a big difference in the life that you live and how long you can live. And I don't know if Dr. Thompson wanna add something more to that.
Yeah, so as a physician, I've come to learn that about 10 to 15% of a person's health is a result of what people in my profession are able to do. And that other 85 to 90% is actually part of what we call the social milieu that a person lives in. And that's quite disparate across our country. Those things like access to education, access to healthy foods, access to transportation, access to recreation, these are all part of the social milieu that we live in, and those are things that contribute overall to not only individual health, but population health as well. There are other Western developed countries that spend more on social programs than per capita than the United States does. We have plans to help the United States spend more on social services, but it is a political issue, so we'll get into that a bit.
So I'm learning something here already. I guess I have an impoverished view of this issue of health equity, but I heard you say many things. Clearly, there are economic issues, but also geography matters, investments that the government makes, the programming that's available through government supports and things like that. What else is involved in this issue of health equity that help me paint a richer picture for myself?
So we've mentioned access to education. There are countries where public education through college is free. That education, as many of you know, provides a pathway for your future. And so that's one area. And then just jobs, where are jobs located? It's interesting, just returning from Ireland, which is quite a rural country, seeing a pharmaceutical company out in the middle of farms. So everyone in that community has a job. If they want to work in pharmacy, they have a job right there. Rather than having to go to Dublin, for instance, or to Galway to find a job that maybe they don't even like doing that much, but that's where they need to go. So that's another aspect of the social milieu and.
I think there's also other components like race and ethnicity and the way that how we interact with the system. And so I'm going to give you the example of my mother, right? Like every time that she needs care, we need to make arrangement. And she's a U.S. citizen that speaks Spanish. She doesn't speak English. So for her to access healthcare, there's all these different steps that we have to take in order to provide that she can be very independent if there was language appropriate services. But we have to make all this arrangement to get her to access care. And she has 2 daughters that work in public health. So she has a wealth of knowledge protecting her. But if that is not the case for every single individual, and she is 70, she will kill me if she knows that I'm telling you, but she's 75 years old, right? And she is a very healthy person, but we know that we have an aging population, and we talk often about shifting demographics in terms of children, but we also have an aging demographic that where you have many elders that are not English speakers, and their main barrier, even with insurance, is language barrier. And one of the things is that my mom always have to trust our interpretation. So she don't even have the privacy of going to the doctor and telling them her secret if she want, because she always need to deal with someone else. So that's an example of another barrier for some groups. There's research that demonstrate that race influence the way that providers interact with you. Like and maybe Dr. Thompson can talk a little bit more about these notions around pain and pain management, for example. There's studies that demonstrate that there's some bias in the way that we treat pain in patients. So when we think about health equity, there's all these components. Gender is another issue. Women are more likely of dying of a heart attack in a hospital because they're less likely to be screened for cardiac conditions. So there's different social conditions that create the structures.
Dr. Thompson, anything to add to that?
Well, I certainly, one of the cool things about public health is that it's used to dealing with these social determinants of health, and their policies have always been more culturally sensitive than within the structures of organized medicine, I would say. And that's changing, but it's not, it hasn't even caught up with what is available through a public health system that has been in place for 30, 40 years, working that way. The organized medicine is kind of transitioning to that. There's other inequities, people with disabilities, that there's very, if you're not able to get out of the wheelchair, then it's likely you're not going to get a physical exam. That's just how it is. And that's not right. It takes more time to get out of a wheelchair and get up onto an exam table. It takes more energy to do that. But physical exam is important if we're going to be treating patients. So there are, even within organized medicine, there are these disparities.
I just happened to be listening to Oregon Public Radio here last week, and there was an interesting story about transgendered transgendered people seeking health care, and concerns about the medical profession and its limited expertise in treating people that had gender reassignment surgeries and things like that relative to healthcare kinds of things. So I guess what I'm lending is that you're helping me think more broadly about barriers, things that get in the way of us reaching what might be called health equity education. It's not just a matter of will and investing dollars, but there are clearly these other social determinants of this, as you say. What else are we missing? What's keeping us from achieving health equity in our society?
Well, the inequities seem to be getting larger, more disparate, and that has to do with our social structure. Some of that has to do with the distribution of wealth in our society, and it's not heading in the right direction. So there's opportunities to change that. There's opportunities, like in the field, my current passion is in universal health care. So there's ample opportunities to learn more about what universal health care has to offer, and see how that compares to what we have at the present time. So what universal health care does is it provides everyone with basic health care. And in the countries that have adopted this policy, their populations are actually healthier than in the U.S. population.
Investing less.
Investing less, yes, costing less. So the way our structure exists today is there's a barrier to moving in that direction.
A political barrier? A money barrier? What?
Yeah, so it's both. It's political, driven by money. So to give an example, when the Affordable Care Act was being negotiated back in 2009, 2010, there were about 3,600 lobbyists from the American Medical Association, the American Hospital Association, the pharmaceutical industry. So 3,600 lobbyists at the table negotiating for what it was that they wanted. And so there's about 600 federal legislators. So that's 6 lobbyists for every federal legislator is what was facing the effort to move the needle much further towards universal health care than was able to be moved. The pharmaceutical industry, for instance, claims that they spend all this money on research, but their balance sheet doesn't show that. They spend more money on marketing, advertising, and lobbyists than they actually spend on research. So it's interesting as you get into this, you can get a better understanding of what the barriers actually are.
I think additionally to what Dr. Thompson is saying, I think that when we think about health policy, if we're seriously want to consider social determinants of health, and I'm going to quote Dr. Dave Williams on this, education policy is health policy. Transportation policy is health policy. So we're in the College of Ed. We have a lot of colleagues that do education. We know that one of the issues that we face, and probably one of the things that is creating gaps in health, is the gap in early education. We know that not kids come to first grade as prepared as they should, right? And many colleagues talk about this, my friends talk about it, teachers talk about it. They have a first grade where they have these children that have been in these tremendous great pre-Ks and kindergarten programs, and you have children that never has been in any pre-K program. So just starting there, you have this disparity that take many of these children for different paths, right? And then if we think about Head Start as health policy, Head Start was a critical program in reducing health disparities. And when we try to understand health and what we have been able to accomplish, Head Start has been at the heart of that. So when we think about health, it's not just health, but education. And early childhood education would be an example. Transportation, urban planning. So we have to expand not just to access to healthcare, but how can we address all these different social determinants of health that are causing this gap in population, in life expectancy, in the type of life that you can live. We need health for everything that we do. To be a citizen, to work, to produce, to raise healthy children, to have healthy families, right? So health, it's at the core of everything that we do. So if we want to address health equity, we really need to revisit how we care for everyone, right? And how can we allow people to make decisions under the right conditions, right? Not making a decision between paying the rent or taking my child to the dentist.
Those are real issues.
And you touch on the whole stream of thought where, as far as policy goes, where the idea is to have health in all policies. So if you're looking to, if a city council is looking to figure out where they want to site a neighborhood, they want to think about, well, what services will be available to that neighborhood? Are all the food markets across town, or will it be easy for people to get to a food market, to walk, get some exercise to be able to walk there? So, and if not being able to walk, at least that there's bus service to where they can go to get healthy food, and they're not having to go to 7-Eleven to make dinner. So this is a concept of health in all policies, where parks get placed, where certain industries get placed within a city, is another part of that health policy.
You're making me understand that this is a very complicated issue, and it's all connected. I was a little dismayed at your characterization, Dr. Thompson, of that we're sort of losing ground relative to health equity. Clearly the rollback of Obamacare is a piece of that, but I'm curious to hear your opinions about, does Oregon have unique challenges or perhaps even unique opportunities relative to health equity?
I can jump in a little bit. I think that I think that there's a couple of interesting pieces I think to consider in Oregon. So Oregon have experienced a shift in population. There's been major shift. So if you look at some rural communities now, you have minority communities where if you look at the school districts where the majority are minority students, right? But this is fairly new in Oregon. So in terms of the human capacity to address some of these needs, I think that are very different challenges that if you're talking about New York or you're talking about other states that have experienced some of the shifts early on and have been able to think about it. So that would be an example of some of the challenges. I think that Oregon now, and I forgot the name of the policy, but we include all children regardless of the documentation status in our the services, the insurance that we provide for children. But we're also facing some challenges in terms of tax policy, right? And how you can, and that those changes at the federal level will have an impact on Oregon, and then therefore that will have an impact on our capacity to serve all children. So those will be some examples. Population shift, I think that difference in state policy versus federal policy, and the shortage of healthcare providers in rural communities.
Well, that's very true. There's a big urban-rural divide in our state that presents all kinds of different challenges. Fortunately, some of the changes that are happening, there's a lot more telemedicine being done, where like OHSU, for instance, will have available some consultative services to the smaller communities. So those are good things. Also, I think Oregon in general is a leader in terms of how we try to provide for as many people as possible in our state. I mean, that's what the Oregon Health Plan was all about. I was in training when that was being first started with then Governor Kitzhaber, and it was a brand new concept that we would actually come up with a list of services that would everybody who qualified, who were low income, would qualify, would be able to access. So that model and the way that list of services got developed was through community, a large community outreach to find out what people in different communities around Oregon actually needed and thought was important, and also the medical input. What things that we do always work, and what things that we do hardly ever work. Those things we're not going to do anymore. We're not going to pay for those things to be done. That whole model was really set the stage for many other states and how they set up their systems. So we have this history of being progressive in our thinking and acting, and currently that continues. So we are, and this is in terms of the field of medicine. But it also has to do with if you have access to health, your life will be healthier. If you're able to treat diseases and afford medicines, your life will be better. So what we're hoping to see in this upcoming short session of our legislature is a constitutional amendment that it is the obligation of the state of Oregon to provide health care to all of its residents, not just legal residents, all of its residents. Doris referred to the Cover All Kids program that just got funded. So that was called Health Care for All Oregon children. And there were 60,000 children in the state that didn't have health care coverage because prior to that, the program covered all legal residents of Oregon. But the legislature this year passed cover all Oregon children. So that funding is actually in jeopardy because of Measure 101 that's going to be coming up on January 23rd. Even though the legislature, so this is the dichotomy we have in our state, right? Mm-hmm. Even though the legislature agreed to provide this funding, 3 legislators filed a referendum to take it to the voters. So that vote is going to come out on January 23rd, whether or not the citizens of Oregon want to do this funding, which they'll call a tax, but it's actually an assessment on the hospitals. Mm. And the hospital associations are all in favor of paying that assessment, but there are some in the state who apparently are not in favor of that.
Is but the individual taxpayer is not on the hook?
No, the individual taxpayer is not on the hook.
That's interesting.
It's an assessment on the healthcare system. Hmm. And the hospitals realize that if people come in without insurance, they're not going to get paid. People come in with insurance, they're going to get paid. So they're happy to say, yes, we should have that funding so people will have insurance.
You've painted a great picture of what could be. I hate to ask this, but do you want to tell any stories about what real disparities look like in terms of health crises in communities? I mean, what can happen if we don't work toward health equity? There's got to be some good stories in the field about real challenges that communities have faced.
Do you want to address that one?
Well, there's 2 parts to that. One is the effects on individuals, and there may be people in the audience here that could actually speak to that have a story to tell about what it means to have health insurance and health coverage. And then there's an aspect of it in terms of how it affects the public health efforts to make communities more livable, more safe, more culturally aware and sensitive. So there's two areas. Individual stories are heartbreaking, and once you start listening to them, you get a very deep sense of what it means to not have health insurance when you need it. My son had a spinal cord injury when he was 16 years old, and he's now 30 years old, and because of the funding that was available through Medicaid, he was able to graduate from the U of O and Honors College. He's written a novel, hasn't got it published yet. He volunteers on the City of Eugene Human Rights Commission. He's a co-leader in a writers group in Eugene. And if he loses the funding to pay for his caregivers, then he's not going to be able to do those kinds of things. This morning we were at LBCC and we were exchanging stories with a group of students, and one student talked about how he had lost the lower part of his leg above the knee, or actually below the knee, and he needed a prosthesis, and it cost $5,500, and his insurance company said, well, we don't think it's medically necessary. So those are the kinds of things that people are facing with the type of health care that even on the commercial market is available. And so it's a matter of understanding what those stories are and where your heart is in terms of taking care of people who aren't as fortunate as I am.
I have an example. I'm going to talk about low birth weight babies. It's one of the most pressing issues in the United States because we have one of the highest rate, if not the highest rate, among the industrialized developed countries. It's very costly for taxpayers. It's probably if I'm not wrong, it's the most costly issue for our healthcare system, and it really has an impact at the individual level and at the society level because of the cost, right? So, and again, this is another personal story. I had two premature babies, and I have seen right there in the NICU how these disparities start developing. When I was able, thanks to the type of job that I have, to the insurance that I have, to take care of my child right there, to be able to advocate, to be 24/7 for the baby, and research said that is critical. When you have parents that are low income, that live in rural communities where are far away from where the NICU, that they don't have the resources, even if their heart is there, they cannot be there for the babies. Right there, the trajectories and the research is very clear in terms of attachment, brain development, their how long they stay in the NICU depend on that. So we have a societal cost because prematurity also have been related to racism and discrimination, high levels of stress, poor prenatal care. So you have this combination of social determinants that is driving this health outcome that is very costly for us as a society. But then at the individual level, you have the impact on the development of a child that the early experience and can determine if they live a healthy life. And now I have two very healthy, thriving, energetic kids. But I know that my story is not the same as a story of many other moms that have gone through the same system. So for me, it's a good example of the individual impact versus the societal impact.
Very real issues. At this point, are there conversations from particularly our students in the audience, or would others like to ask questions or share their thoughts and opinions? Don't be shy.
Stories enrich us, when you listen to somebody else's story. I feel like I grow, I become a more of a human being. So don't be afraid to share.
Well, if no one else will go, I will.
Please.
Thank you,
I'm Brie Wallace. I'm a student that's in community health education and psychology. I can tell you growing up, I didn't have health insurance. I didn't have it until OHP came out. I had feet problem when I was in high school. I went a whole summer with an infected toe. It was awful. Painful to walk on, couldn't wear shoes or socks. And the only reason I got help is because the local doctor did a deal for me for $100 to work on it. And that was my lifesaver because I was like, I haven't had insurance since I was like 13. And I was 16 at the time. And he's like, we have people without insurance? And I was like, yeah, it's an everyday reality. I didn't see the dentist for 3 years. The only reason I got to see it is because the dentist did like a great program through the high school. And I was in a high school of about 600. I mean, I'm from a small community. And it was just, amazing that I was able to be a part of those programs. But I think we need more, and insurance is so important that going without it, you realize what you have. Yeah. And we need to work on that because it's just unfair to not have something that should be a right.
Dr. Thompson, I know there's kind of a tradition of pro bono work in law. Is there something akin to that in the medical profession?
Well, yes, there is. It's not generally widely accepted, but individual practices, probably similar to law practices, individual practices have a little more freedom to to provide services at a reduced or cost-free service. Certainly, if you get into the hospital, that's kind of hard to do. But
Just because of additional overhead or cost of medicine?
yeah, I think the cost of just
Okay.
the cost of running that. Yeah, and your story, this is exactly the kind of thing that's easy to do in a family doc's office. Or
Yeah, they were very small, just mom and pop
Yeah.
community dentist, and I can't remember what the doctor's called. But, you know, I appreciated them greatly. It was just so amazing to be able to go to see a doctor. You know, no physical exam, nothing for 3 years.
Yeah, and there are certainly, in some communities, there are dental vans, so the dentistry community will contribute time and materials to go out to the smaller communities in a county to at least provide basic services. But it's pretty hit or miss. Yeah.
And it's not the ideal way.
No, it's
of
not the ideal way.
providing healthcare. It's not. It's not consistent. It's not the long term. You know, people are not able to achieve a healthy life. That is the only way that
Sporadic,
they can. It's
yeah.
sporadic healthcare.
Yep. Yes, please.
So as far as like chronic illness and treatment of, because for a lot of chronic illness, I feel like the best treatment comes not necessarily from Western medicine, but more like vitamins or they're just holistic medicine. That's the word I'm looking for. But insurance fails to cover that most of the time in the United States. I know acupuncture is starting to get covered, which is really cool. But as far as your experience with working for getting better, like universal coverage, what have you come into including holistic medicine?
Yeah, so that certainly has been discussed, and there are, for the things that there's good evidence for effectiveness of treatment, and certainly acupuncture can be one of those. Those are the kinds of decisions that any system that has, publicly funded has to balance versus how many people are you serving. So, but yes, holistic medicine aspects of it are shown to be effective. So those would be certainly included as far as we know at this point. It's a shifting field.
Our faculty, I'm sure, are bursting with things to say. Anybody want to take a stab?
So the opioid epidemic seems to be front page news every day, and I was wondering if either or both of you would mind commenting on that in terms of health equity.
Well, that is not a simple topic.
Yes.
Yeah, that has huge social ramifications. Certainly, the pharmaceutical industry is complicit in it. Certainly, there was a time when the Oregon Board of Medical Examiners would chastise physicians for not providing enough pain relief for their patients. Now they've swung the other way because of what it created. They're certainly, if you come in with a suit and tie versus come in with ragged pants and ask for pain meds, there's a disparity there, no doubt. Whether either one was valid is kind of off the table. Personally, I've had patients come in, and maybe they got the first prescription okay, and maybe the second one, but soon you figure out that something's not quite right here, and you can weed that out. But for a lot of physicians, they don't have time to do that. It takes a lot of time. So the it's a multifactorial issue and a very sad situation for sure. So many needless deaths from overdosing.
And with the opioid crisis, I think that there's this interesting conversation about what and when we consider something a crisis and who is affected by the crisis, right? So we have different communities that have faced different substance use issues, and in some instances we decide to criminalize that, and in other instances we have a more medical public health approach, right? And if you think about some of the issues that communities of colors faced back in the 80s and 90s with crack and cocaine and heroin, and they were highly criminalized, right? And they were not treated. And now when you see a shift in who is affected by the substance use opioid crisis, then the conversation changed, right? And that also has some implications for health and the long-term outcomes that different communities face. So I think that is a good example of how one health outcome is treated differently depending on the community that is facing that issue.
There's another aspect to that as well, and it highlights the lack in our current system for identifying and treating mental health disorders. So pain is a very subjective thing, and it's emotional pain sometimes isn't very different from physical pain, and so a lot of pain got treated with narcotics when it should have been treated another way, a better way. So that's another aspect of this complex issue.
So as we prepare to begin to close this, I want to take an opportunity for one more question. So this is your cue to think of one more question, right? But then after that one more question, I'd like for the two of you to take an opportunity to speak directly to our students and help them think about what they can do to prepare themselves to be the most effective citizens, to be advocates for health equity in our state and in our country and globally even perhaps. But before we speak directly to students, is there one more question from the audience? Elisa?
So it's about students actually, and student health care and the student health insurance that students are required to have to come to college. So I assume that also causes a disparity, because if a student is unable to afford the health insurance, then they would not be able to come to university or college. And I guess I don't know enough about how that works, but I'm wondering if you know anything about, if students are unable to attend college or university because they don't have insurance.
If we're talking about Oregon, if a person qualifies for Oregon Health Plan, then that's a way around that. At Oregon State, I don't know that that's I know that foreign students have to have insurance to come to OSU, but I don't know about. I'm fairly certain that there are students there that do not have insurance, health insurance. So I think it's probably not a universal policy, would be my guess.
Please, you were about to say?
No. I don't have a lot of information about, but that would be another example, right? Like if we have universal health care, then this wouldn't be a barrier for students to come to college. So, and I understand some public health concerns also why we want students to be covered, and OSU, we were just talking about a meningitis outbreak and
Yeah.
how insurance play in the way we serve students. But again, it's another good example of if we take care of everyone in terms of health access and access to healthcare, then that wouldn't be a barrier for college, or at least another worry for students to put. They already have plenty of worries, so they will remove that.
Indeed, a complicated set of interrelated issues here.
Yeah, more than we can do in an hour.
For sure, for sure. So what would you say to our students?
Well, I would say learn as much as you can, be involved in as many things you can be involved in. There's a Jackson Brown song, do the dance that you've been shown by everyone you've ever known until the dance becomes your very own. And college is a great place to do that, so take advantage of it. I never really thought I would be where I am when I was your age. I was facing Vietnam, and I fortunately didn't have to go. So yeah, you never know what's coming down the road, but make the most of it, definitely. And lots of opportunities to change things. There's no shortage of that.
I think in terms of health equity, one of the things that are very important is become a good citizen. You're getting a degree. You don't know what path you're gonna go. Life changes. You may stay home taking care of your children. You may decide to go, I don't know, to become a filmmaker. But if you become a good citizen, where you are reading and becoming informed and advocating for others, and contributing, we can reduce health equity. So it's not just the degree that you're getting, but it's the role that you're going to play in the society. So you listen to this conversation, we talk about socioeconomic status, race and ethnicity, where you born, your gender, different disabilities, impact health. You can take different paths to address that, but regardless of the path that you take, become an engaged citizen, where you question information, when you seek for information, and when you make informed decisions, the best of your abilities.
Good advice. Please join me in giving Dr. Cancel-Tirado and Dr. Thompson a round of applause. Thank you. So as we prepare to sign off, I'd also just like to one more time recognize our student-led video production team, Q Loop Studios. If we could give them a round of applause as well. They figured out all sorts of things relative to new equipment and new technology. We're apparently live streaming at this very moment. I don't even know what that means, but it sounds pretty cool. But I hope you'll join us for future editions of the College of Education Fireside Chats. Our hope is to tackle other serious issues related to the other academic units in the college as the course of the academic year proceeds. But for this evening, thank you very much for coming, and we will sign off. Thank you very much.
Thank you.
Thank you.
Thank you.